Welcome to your ST 310 Week 10 mini session, Chapter 15, Emergency Situations. Emergency situations during surgery can involve anesthesia-related issues, like allergic reactions and respiratory emergencies. We as STs need to be familiar with the terms and abbreviations associated with these situations. Respiratory emergencies include allergic reactions that require quick administration of medications like epinephrine or antihistamines. There are also 3 types of transfusion reactions that need to be identified and treated promptly to avoid complications. But that's not it. As STs, it is so important for us to understand and address critical emergencies that may arise during surgery. Recognizing and managing things like bronchospasms and laryngeal spasms are so important for ensuring the patient's airway remains secure. We also have to understand the protocols for cardiac arrest, and knowing our role during a cardiac emergency just helps us to support the surgical team effectively in life-saving interventions. But being familiar with drugs commonly used for cardiac resuscitation, as well as other cardiovascular medications, allows us to anticipate the needs of the surgical team and contribute to prompt, efficient patient care. These skills are so important for patient safety and successful surgical outcomes. The slide in front of you is terms that are really important for you to understand. For example, a severe allergic reaction to substances like proteins, it's a type of respiratory emergency, is anaphylaxis. To tachycardia being a fast heartbeat of greater than 100 beats per minute, and is an early sign of malignant hyperthermia. Understanding all the terms on this slide and the conditions are so important for understanding emergencies and reactions during surgery. I cannot stress it's going to be key to your success in the operating room. Respiratory emergencies during anesthesia include, as I mentioned earlier, bronchospasms, laryngeal spasms, and even anaphylaxis. Rare, but critical emergencies are cardiac arrest and malignant hyperthermia, which we're going to talk about in more detail in this mini session. So for us, we need to know the emergency medications commonly used to help manage these situations effectively. Now, Table 15.1 shows the generic names and purposes of drugs used for respiratory emergencies. Respiratory problems during surgery can happen for many reasons, such as blocked airways, anesthesia reactions, or just other complications. Let's start off with allergic reactions. We have mild allergic reactions, including skin redness, hives, or raised patches. If early signs appear, potential triggers should be stopped immediately. Allergic reactions can develop within 2 to 20 minutes and last up to 36 hours. H1 and H2 receptor antagonists, like Benadryl, are used to counteract the release of histamines. If mild treatments don't work, the reaction can escalate to anaphylaxis, which is a severe, life-threatening allergic reaction with respiratory symptoms. Anaphylaxis occurs in 1 in 4,000 to 25,000 cases of anesthesia. Epinephrine is the first line of treatment, and corticosteroids may also be used. If not treated quickly, anaphylactic shock can cause full cardiovascular collapse, including cardiac and respiratory arrest. Now we look at hemolytic transfusion reactions. These again are rare, but important allergic reactions that occur when incompatible blood is given during surgery. So they have a couple markers. hypertension, which is high blood pressure. They have hemoglobinuria, which is blood in the urine. We have anuria or oliguria, which is a lack of urine, fever, or disseminated intravascular coagulopathy, which is DIC. Now, the first step in treatment is to stop the blood transfusion immediately. There are 3 types of transfusion reactions. You're going to want to make sure you know these. Febrile, non-hemolytic, which is caused by antibodies attacking the donor white blood cells or platelets, again, rare in surgery, allergic, and hemolytic. Now, bronchospasm is a condition where the bronchi constrict and become inflamed, causing impaired breathing. So some of the signs include wheezing, prolonged exhalation, decreased breath sounds, lower oxygen levels, increased airway pressure during ventilation, as well as hypotension. The anesthesia care provider will first check the mechanical issues. Then they may give some treatment. They have a couple options. They can do beta adrenergic agonists like albuterol or epinephrine, or antichlorhydrics like atropine. If bronchospasm continues, corticosteroids like hydrocortisone may be used, typically through IV, but sometimes inhaled. Laryngospasm is the voluntary tightening of the vocal cord, which can partially or completely block airway. It can happen during intubation or soon after extubation. How do we treat this? Well, positive airway pressure with a mask or chin lift. Sometimes you'll have succinylcholine, which is a muscle relaxant, if the spasm doesn't resolve, and then atropine for treating bradycardia in pediatric patients caused by low oxygen levels. Now, patients are most at risk when lightly anesthetized at extubation, especially children and infants. Now, cardiac arrest is the sudden loss of heart function, breathing, and consciousness, often called a code blue. It can happen before, during, or after anesthesia is administered. In this situation, our role will depend on the specific scenario and should include supporting the team and providing life-saving measures. But let's talk a little bit more in detail. Again, our role is going to vary, right? Depending on our position and the specific circumstances of the event. But I'm going to give you a little outline. All right, as the scrub, we're going to maintain sterile field while assisting the surgical team. This may be helping with administering medications and ensuring equipment is ready for emergency use if needed. The second assistant assists the surgeon with procedures as needed as well, like holding tissue or organs during resuscitation efforts. This helps to just make sure instruments are available for the team to use quickly. If there's a surgical first assist, they're going to work closely with the surgeon to provide more hands-on assistance. May need to assist in advanced procedures like chest compressions or using the defibrillator. Our circulators are going to ensure that the operating room environment is set up for emergency procedures like managing medications, managing supplies, and communication with other medical teams. They're also going to be the individual getting the crash cart, which contains essential equipment such as medications and the defibrillator, and ensures it's available. Our anesthesia provider is going to manage the airway and ventilation. The surgeon is performing resuscitation procedures if needed and directs the emergency care. All other nurses and other staff may assist in the resuscitation by monitoring vitals and providing other necessary support. The key is all members of the surgical team have to work together to stabilize the patient, with every role being critical in the success of the cardiac emergency response. Keep in mind that we all have to be certified in American Heart Association Basic Life Support at the healthcare level to respond effectively in these type of emergencies. Now, the chapter summarizes key drugs used for cardiac resuscitation. Now, epinephrine, often the first line of treatment for cardiac arrest. Lidocaine is given only if amiodarone is not effective. But there's some things you have to keep in mind, some terms. If you hear no heartbeat or asystole, that's a problem. Bradycardia, slow heartbeat, or tachycardia, rapid heartbeat. These drugs and terms are so important for understanding cardiac emergencies and actually how to treat them. But there's also miscellaneous cardiovascular drugs. That means that we need to be familiar because these are also important in managing cardiac emergencies. Everything from vasodilators, which relax blood vessels, reducing blood pressure, to cholinergic agonists and antagonists, where they're affecting the parasympathetic nervous system, with agonists stimulating and antagonists blocking it. So the drugs you see on this slide are important for us to just know in case we have to assist effectively during cardiac emergencies. Let's look at adrenergic agonists. These are also called simple themametics. They mimic the effects of the sympathetic nervous system, often increasing heart rate and blood pressures. Some of the examples you see on the screen, from dopamine to norepinephrine, or even albuterol, also used for bronchospasms. Now, adrenergic antagonists, also called sympathaholics, they block the effects of epinephrine and non-epinephrine. These drugs are commonly known as beta blockers and specifically work as beta adrenergic antagonists, meaning they reduce heart rate and blood pressure. With your cholinergic agonists, also called parasympathetics, and your cholinergic antagonists, also called anticholinergics, they primarily affect the parasympathetic nervous systems. Now, your cholinergic agonists stimulate the parasympathetic system, but are not typically used for treating cardiac conditions. Your cholinergic antagonists block the effects of the parasympathetic system, such as atropine sulfate, which specifically blocks the vagus nerve influence on the SA, which is the sinoatrial node of the heart, increasing heart rate. We have our antirheumatic agents. They are used to treat or prevent irregular heart rhythms by affecting the force of or rhythm of the heart. They are classified in 4 classes that you see in front of you. Class 1, these drugs slow the electrical impulses in the heart. Class 2, they block the effects of adrenaline, reducing heart rate and blood pressure. Class 3 helps stabilize the heart rhythm by prolonging the repolarization phase. And class 4 relax blood vessels and reduce heart rate by blocking calcium into heart cells. Now, each class targets specific mechanisms to help restore normal heart rhythm. We have to talk about our vasodilators, intratropes, and vasopressors. Now, dopamine and epinephrine are both classified as inotropes, which increase the strength of heart contractions. Vasopressors, which raise blood pressures by constricting blood vessels. Your vasodilators are drugs that relax smooth muscle cells in blood vessel walls, leading to widening of the blood vessels and lowering blood pressure. Intropes and vasopressors are used to increase blood pressure by improving heart function and constricting blood vessels. Now, the second part of chapter 15 gets into a really serious condition, malignant hyperthermia. Now, malignant hyperthermia is a life-threatening condition that requires us to act quickly and effectively as part of the team. Recognizing clinical signs such as rapid rise in body temperature, muscle rigidity, and tachycardia is so important for early intervention. Treatments involve discontinuing triggering agents, administering dantrolene, cooling the patient, and monitoring vital signs closely. But we're going to break this down even more. Malignant hyperthermia is rare, but it's life-threatening. It's a reaction to certain anesthetic agents, and it happens in susceptible individuals. It's a rapid onset. Malignant hyperthermia can become fatal in as little as 15 minutes. Untreated malignant hypothermia has a mortality rate of 80%. So you're looking at prompt diagnosis and treatment. This is going to be what's important for survival. Now, there are some trigger agents. Circulator, which is a muscle relaxant, all inhalation anesthetics except nitrous oxide, and some antipsychotics. These agents can trigger MH in susceptible individuals, so it's going to be important to avoid them during anesthesia when possible. Malignant hyperthermia occurs when individuals with genetic defects in the cerebroplasmic reticulum, which stores the release of calcium, are exposed to certain trigger agents. You have a genetic inheritance. 50% of offspring inherit the defect. But the trigger plus the susceptibility have to be present for MH to occur. The exposure to triggers causes massive release of calcium in muscle cells, leading to sustained muscle contractions, increased metabolism, excessive heat production, oxygen depletion, and carbon dioxide buildup, resulting in acidosis. Muscle cell breakdown releases myoglobin into the bloodstream, which can clog the kidneys. Immediate treatment is so important to prevent kidney damage and severe complications. So we look at the earliest signs of malignant hyperthermia, often subtle, but so important to recognize. We're going to watch a quick little video that breaks this down.
Malignant hyperthermia is exposure to volatile anesthetics, such as halothane, and depolarizing muscle relaxant, such as succinylcholine, in those who are susceptible. Susceptibility can occur from mutations in different genes. Researchers have identified at least 6 forms of malignant hyperthermia susceptibility, caused by different gene mutations. The most common is a mutation in the RYRI gene, which is responsible for a form of the condition known as MHS1. Others include mutations in the CACNA1S gene, which is responsible for a form of the condition known as MHS5, and the CACNAD21 gene, which has been linked to a form of the condition known as MHS3. Susceptibility is usually inherited in an autosomal dominant manner, which means only one copy of the mutant gene is necessary for an individual to inherit the disorder. There are numerous reports of susceptible people who have developed symptoms in association with the biological stress of physical exercise and/or heat exposure. The disorder may also occur with some inherited muscle diseases, such as central core disease. Before you have surgery, it is very important to inform your doctor if you are aware of any malignant hyperthermia susceptibility in your family. Symptoms: a very high temperature, muscle rigidity, rhabdomyolysis, the breakdown of muscle fibers, a rapid heart rate and abnormally rapid breathing, acidosis, an increased acid level in the blood and other tissues, increased carbon dioxide production. These symptoms can develop any time during the administration of the anesthetic triggering agents. Diagnosis and treatment. Diagnosis is suspected by the appearance of typical symptoms a few minutes or several hours following administration of anesthesia. Earliest symptoms may include muscle rigidity, unexplained fast heart rate, and abnormally elevated carbon dioxide in the blood. Those with a personal history of a severe adverse effect to general anesthesia, or with a close relative who has suffered an episode of the disorder, are usually recommended for testing. The standard procedure is the caffeine halothane contracture, or CHCT. This test measures the response of a muscle tissue sample to caffeine and halothane and can be done only at certain referral centers. Genetic testing may also be performed to determine susceptibility. Treatment. Treatment options include intravenous administration of dantrolene. Dantrolene remains the only drug known to be effective in the treatment of malignant hyperthermia. Rapid cooling. Discontinuation of triggering events. Supportive therapy directed at correcting organ dysfunction and acidosis. Thank you for watching our video.
And I love how it really broke it down for us to kind of see the early signs and even the treatments. Again, I cannot stress that it is a rare but serious reaction triggered by those anesthetic drugs that were mentioned. So, like they mentioned, we're going to eliminate excess CO2 from the body by hyperventilating with 100% oxygen. You heard dantrolene, which is that muscle relaxant that stops the abnormal muscle contractions that's caused by the malignant hyperthermia. Sodium bicarbonate is used to treat acidosis, which is that excess acid that happens during malignant hyperthermia. And then you heard we've got to get the patient cooled. So we may use ice packs because we want to prevent brain damage. Mannitol, which is diuretic, prevents kidney damage by helping to just flush out harmful substances like myoglobin that is released from muscles. Insulin treats high potassium levels caused by that muscle breakdown during malignant hypothermia. So for us, it's important just to be familiar with the drugs and equipment used in malignant hypothermia. You may have to help with oxygen administration, cooling, and preparation of medications. But we work as a team. We're supporting the anesthesiology team and making sure that everything is ready for treatment without delay. So that means that we have to act fast, stay calm, but we're there to help manage this life-threatening emergency effectively. First and foremost, stay alert. Stay focused on the patient and the environment. If you are not paying attention, you cannot help identify or respond to a crisis early on. Awareness is key to providing effective assistance when needed. Again, be aware of the clinical signs of a crisis and be prepared to act quickly, focusing on the patient, assisting anesthesia when needed. If MH is suspected, the anesthesia and surgery stop immediately. If the procedure continues and you're in the first scrub role, you're going to stay sterile. You're going to monitor the surgical site and assist as needed. You may also help by handing over ice saline irrigation. In the second scrub role, if necessary, you may break scrub to assist in going and grabbing the ice, bringing in more help, or reconstituting dantrolene if no one else is available, such as during an on-call situation. The circulator is there to kind of help with everything. They include setting up ice lavage for areas like the bladder, the rectum, and abdomen, and again, reconstituting dantrolene for administration. In an MH emergency, tasks happen so quickly and in parallel. Knowing the procedure and being prepared to act helps the team respond effectively. But the biggest thing, stay calm and focus. Patients at risk of MH will not be given triggering agents to prevent a crisis. Now, MH is one of many emergencies that can occur in surgery, and each requires quick thinking and support from us as STs. The more knowledge you have, the better you'll be able to assist the anesthesia provider and respond effectively in an emergency situation. Now, This chapter covers the critical role of us as STs in emergency situations like MH, which is a rare but life-threatening condition triggered by certain anesthetics. The key to responding to MH is recognizing early signs such as increased CO2, tachycardia, muscle rigidity, and fever. Early action is important, including hyperventilating with O2, administering a dantrolene, and using ice packs for temperature control. We play an important role in these emergencies, whether as a scrub, a second assistant, or yes, even the circulator. Being prepared, staying calm, and knowing what steps to take can make a significant difference in saving lives. And this is our mini session, Chapter 15, Emergency Situations.